Well, the field of endocrine tumors in general is changing, and it is changing because we know more about the biology of the tumor, the drivers, the molecular drivers that are leading to the growth of these tumors. Speaking about thyroid cancer, well, we have the precision medicine in the algorithm of treatment of patients with differentiated thyroid tumors, in patients with medullary thyroid carcinoma, and also in anaplastic tumors. Medullary thyroid tumors are treated not only with multikinase inhibitors, but also with selective RET inhibitors. In anaplastic thyroid cancer, we have included in the ESMO guidelines what to do for patients with B-RAF mutations and also NTRK fusions and maybe RET fusions. And in those patients refractory to radioactive iodine with differentiated thyroid carcinoma, we have the potential use of NTRK inhibitors, B-RAF inhibitors, and RET selective inhibitors because of the percentage of patients harboring fusions on the RET gene. The most impactful trial that has been presented in the endocrine sphere has been related to a plenary session led by my friend and colleague Dr. Julian Hadux, in which the LIBRETTO-531 trial compared in the first-line setting the use of a RET selective inhibitor like selpercatinib versus the what we use, the multikinase inhibitors that we were using in this setting, mandetanib and cabozantinib. The data are amazing. The primary endpoint, the progression-free survival, was met with a hazard ratio in the range of 0.2. So this is impressive. This is overcoming what we have. This is exceeding the expectations. So highest response rate, highest longer progression-free survival, and a clear trend to improve the overall survival. I think the selection, the RET selective inhibition, should be the first standard of care for me in this setting. Moving to the field of neuroendocrine tumors, what do we have so far? Well, Dr. Jennifer Chen presented the data of the CABATEN Alliance-led trial in which patients with gastroenteropancreatic tumors were randomized to receive cabozantinib versus placebo. These patients were they had prior progression to everolimus. So this is a very heavily pretreated population. In both cases, patients with extrapancreatic tumors and patients with pancreatic tumors with grade 1 and 2, well, cabozantinib did it better for the primary endpoint of the trial, progression-free survival. So cabozantinib is welcome as a new treatment option in the sequencing treatment of our patients with gastroenteropancreatic G1 and G2 neuroendocrine tumors. Other data has been presented. Jan Capdevila presented the data of the CABATEN trial combining cabozantinib and atezolizumab. Well, some responders, but unfortunately not as many as we expected in this Spanish task force group for neuroendocrine tumors led trial. So we need to think to which patients immunotherapy is really adding anything in the field of neuroendocrine tumors. This is the challenge that we have.